Hello, and welcome to my podcast. In this episode, I will be going over some common musculoskeletal lower back pain diagnoses. It is worth bearing in mind that these are just the common things we or most manual therapists tend to see. It is by no means a complete guide of diagnosis for lower back pain. If there is any interest or request to do a complete and thorough guide on back pain diagnosis, one shall be done in the future. And if you have not listened to my first episode on how I diagnose and my framework around diagnosis, then please listen to it first before listening to this episode. It will make much more sense. By the end of this episode, you will learn about the 5 or 6 most common lower back pain complaints and some simple, quick, and easy things to try and alleviate any discomfort. Although this is not the main focus of the podcast, this is generic advice that can be applied and tried relatively quickly. Specifics on how to diagnose each one will feature in another episode. It is important to note that there is not usually one single cause of back pain. I have laid out 5 separate diagnoses for the sake of simplicity. In reality, there are maybe 1, 2, 3, or more of these at play at any given time with mechanical back pain. Think of these diagnoses as the main culprits in their presentations. As always, the first step is to rule out any red flags. This process starts with the first contact you have with your patient, usually on the phone when they book an appointment. For example, it typically takes less than 30 seconds to ask the basic cauda equina questions over the phone. Not difficult. Just for perspective, 99% of back pain will be musculoskeletal in origin, with 1% being pathological. Don't get caught out in that 1% bracket. Lower back pain is a very common occurrence and can happen at any age and at any time. It tends to manifest in relation to one or more of the following key factors. Number 1, birth defects. For example, spina bifida, narrow spinal canals, or congenital abnormalities. Number 2, injury, lifting with poor form, traffic accidents, traumas, and so forth. Number 3, psychosocial reasons. For example, depression, stress, divorce. Number 4, built up gradually over time. For example, degenerative conditions, wear and tear, osteoarthritis, degenerative disc disease, and so forth. Number 5, recurrent cycles of lower back pain. For example, due to poor conditioning, tone, use of body, poor physical health. Number 6, systemic issues. For example, aortic aneurysms, kidney stones. Number 7, disease process. For example, autoimmune conditions such as ankylosing spondylitis, cancer, endometriosis, infection, and so forth. Number 8, environmental factors. For example, pollution, humidity, mold at home, and so forth. Number 9, lifestyle. For example, diet, smoking, alcohol, drug use, so forth. Number 10, idiopathic. For example, this means of no known cause. Number 11, iatrogenic, which means due to medical error. And lastly, referred pain from another source or structure, such as right shoulder pain and a gallbladder or liver or lung referral. As a bonus point, see if you can spot the red flags in the categories I just spoke about. Remember, we are talking in the context of mechanical lower back pain. Let's now dive in to the 6 most common causes of lower back pain. Number 1, disc herniation / discogenic pain. There are two common scenarios here. The first one is where the disc bulges to one side, pressing on nearby nerves and thereby provoking pain down the leg. In the worst case scenarios, you can have a central herniation, whereby the disc can bulge towards your spinal column, which would generally mean symptoms down both legs at the same time. The second is disc irritation without bulging, which would lead to mainly back pain only if there is no substantial inflammation present. Some of these structures can also refer pain to the buttock area with this presentation. With this kind of presentation, you would have morning stiffness or pain. You would find it difficult to put your socks and shoes on, find it hard to sit for prolonged periods of time. If you have irritated the nerves, you might also feel pins and needles, sharp shooting pains, numbness, or a feeling that your leg might give way. This is your typical sciatica. The good news is that most disc-related issues heal on their own within 4 to 8 weeks, depending on their severity, your metabolic and psychosocial health. If you have pain down one leg, try gently moving your spine in a direction where it feels easier and/or the symptoms down the leg start to ease very slightly. For a herniated disc, this is usually by bending backwards. If this works, then perform 2 sets of 10 reps every 4 hours for the following week. This, by the way, is a very good prognostic indicator and shows that the pain will heal relatively quickly. If this does not work, or you have no leg pain, then avoid sitting down for prolonged periods of time. Keep walking and ice regularly for up to 3 times a day for no more than 15 minutes and no more than 5 days in a row. You must pay attention of how you're moving your body, how you sit, how you get up, how you sleep at night, and move around generally. Addressing these things can make all the difference. Monitor your level of discomfort and pain as you are moving around using a 0 to 10 scale. Make sure you do not go past 4 to 10 in the acute stage. Number 2, facet joint syndrome. Like a disc herniation mentioned above, there are 2 main patterns to this presentation. Either the joint itself can cause pain and/or there may also be narrowing of the space where the nerves exit. This may result in pain around the groin area or down the leg, similar to sciatica. As a brief side note, sciatica is not an actual diagnosis. It is usually one of 3 things: a disc herniation pressing on the L4, L5 nerve roots, facet joint syndrome, pinching on those same nerves, or piriformis syndrome, which is directly pressing on your sciatic nerve at the back of your hip. So, with a facet joint syndrome presentation, you will usually feel pain on one side of the lower back, have difficulty with transitional movements, such as turning around in bed, getting up from sitting, twisting and rotating, and you would prefer to sit rather than stand or walk. You might even find relief from leaning forward slightly. Although these presentations are relatively easy to address, they can turn into a chronic problem if the underlying causes are not addressed. These are usually faulty movement patterns. The best exercise for these is usually a posterior pelvic tilt, as this directly opens those facet joints. Another important principle to incorporate is the use of your hips and not the lower back. When you rotate or want to transition, use your hips and lower back in tandem together rather than twist through your lower back. This will instantly feel better for any facet joint related pain. The use of ice above can also be helpful, but not for too long. You do want some of that inflammation to be there in order to heal and clean and repair what's happening. Number 3 are your sprains and strains. Most commonly presents in muscles or ligaments and typically results from overstretched or fatigued, weak, tight muscles in combination with faulty movement patterns. This can either happen suddenly or with one movement, or due to a combination of repetitive movements over time. With regards to ligaments, pain and dysfunction are mostly related to excessive stretch and tension. Think of a wrist sprain when you fall over, or that time you twisted your knee changing direction. With both of these presentations, the pain would predominate mostly around the stretching of the soft tissues involved, or the activation of a weak and fatigued muscle. There may also be some swelling, plus or minus bruising, stiffness, weakness, instability, and/or muscle cramps and spasms. Self-massage and trigger pointing, regular gentle movements, and ice are the easiest remedies to try. The grade of the strain, from 1 to 3, will determine how long the healing takes, ranging anywhere from a few days to a few months. Number 4 is spondylosis, also known as arthritis of the spine. It is essentially a term that describes wear and tear of the lower spine. The main presentation is spinal pain, stiffness, and a reduced range of movement. Due to the fact that spondylosis indicates spinal arthritis, there can be many different presentations aside from just back pain. It can affect the nerves due to the narrowing of certain spinal joints, like this facet joint syndrome above, or even the disc itself in degenerative disc disease. Generally speaking, you would have spinal stiffness when you first get out of bed, easing off within the first 30 minutes of you moving around. A sensation of stiffness when being in one position for too long, and a general reduction in the range of your spine. If it is also affecting your facet joints, you may also feel back pain with prolonged standing and walking. The older you are, the more likely you are to have degenerative findings in your lower back. However, having these findings on X-ray does not mean you will automatically have symptoms. Far from it. Some people can have severe lower back pain with no degenerative findings at all on imaging, whilst others can have an X-ray showing severe arthritis and they will have no pain whatsoever, playing golf 3 times a week and tennis the other 2 days a week. Listening to the patient, taking a good case history and a detailed, thorough clinical examination will support the correct diagnosis and most effective treatment. Number 5 is sacroiliac joint dysfunction. There are 2 sacroiliac joints in the body situated between the pelvic bones and the lower part of your spine. Dysfunctions usually arise due to either too little or too much movement. In each of these categories, there are several common diagnoses. In terms of excessive joint movement, you would mainly see this during pregnancy, muscle weakness, patients with hypermobility, or alternatively repetitive micro or macro trauma. Generally speaking, you would have pain to one side of the lower back, buttock area. Sharp stabbing or shooting sensations down the back of the leg to the knee. Difficulty bending forwards, sitting, walking, even more so on uneven surfaces, lying on the same side of the pain, or climbing stairs. There might even be instability or a sense of limping on that same side of dysfunction. In terms of reduced movement, this can happen due to either degenerative changes, such as osteoarthritis, certain specific autoimmune conditions like ankylosing spondylitis, which would lead to a term called sacroiliitis, i.e. inflammation of your sacroiliac joint, which is not the same as a mechanical SI dysfunction. Uneven leg length pelvis inequalities, although this must be marked to have a clinical difference, and or increased soft tissue tension. Management for a sacroiliac that moves too much would emphasize the need to support stability above all else. This is done by strengthening your core, which includes your glutes, by the way. and working on your movement patterns, bending forwards and in any way that does not stress those joints overly. In terms of treatment, we teach you how to use muscle energy techniques to help stabilize the nasi joint that moves too much. Or we use the same energy techniques to restore tight, weak muscles that are reducing the movement of your SI joint. You do not stretch tight muscles. This is such an important concept to understand, and we'll have an episode on its own soon. A simple exercise to try is as follows. Lie on your back, bring your affected leg to 90 degrees so that your knee is above your hip. Place your hand around your knee and push your leg towards the floor for 8 seconds. Nothing should be moving. This is known as an isometric contraction. You will be pushing your knee into your hand, gently with about 20% of force. Relax for a second, and then repeat this cycle 4 times in total. As a side note, when I talk about the SI moving, I don't mean a lot of movement. It's virtually millimeters in reality. But it's a relative concept to understand, as this joint's job is to provide stability. So anytime there is a little bit more movement than normal, the SI joint is relatively unstable than it should be. Lastly, number 6 is the concept of hypermobility. Although this is not a diagnosis per se, it is a huge predisposing factor for back pain in general. And technically speaking, spinal instability is the associated diagnosis that has ligament laxity as its main predisposing factor. Our ligaments connect one bone to another. Due to gravity and how we move and function, your ligaments will be shorter or longer, i.e. stretched, or anywhere in between at any given time. For example, if you are slouching, the ligaments at the back of your lower spine will be longer than if you were standing upright. The longer a ligament is stretched, the more likely it will creep. Unlike muscles, ligaments take much longer to revert back to the original size when able to do so. So if someone is slouching all the time, chances are that their lower spinal ligaments at the back of the spine are longer than they should be. This induces a state of relative instability in the spinal joint. A joint is where 2 or more bones meet to form a movement. Your brain hates any sense of instability and will do everything it can to stabilize these joints, as it's incredibly sensitive to any of these tiny micro movements. The principal way this is achieved is by tightening the muscles that control that joint. This innate system works well until you start stretching it, or the joint gets more unstable over time due to the fact it is being held in its relatively long position. Both of these scenarios result in even tighter muscles, and one of the many causes of back pain. On one final note, here is some general advice you should try with any type of mechanical pain. Find a position that tends to ease the pain and work from that point. Move as much as possible without going above a 4 out of 10 on your personal pain scale. Avoiding the daily, weekly, or monthly triggers is one of the most important pieces of advice, and it alone can likely resolve most conditions. Do not become fear avoidant. Use and move as much as you can and as quickly as you can within that 4 out of 10 pain scale. Not moving, being fearful, or guarding a joint only leads to bad outcomes in the future. So there we have it, the 6 most common lower back pain diagnostic categories. It is worth noting that some of you might say spondylosis, sprains and strains, and hypermobility are not diagnoses, and I would 100% agree with you. It is just easier to categorize them that way when thinking and talking about different mechanisms of pain and dysfunction. As always, thank you for listening, and if you have any questions or comments, then please do not hesitate to get in touch. Take care.